Now that we've covered the introductory topic of trauma-informed care, we'll look into the tools, recommendations for how to apply that in emergency medicine. Working in emergency medicine comes with a very diverse patient population and a wide range of chief complaints, and it's critical to be able to identify what of those are life-threatening. For clinicians who work in demanding situations, recognizing and managing emotions is especially important. They may recognize they are lacking in empathy, but don't take steps to improve it. Compassion fatigue is a form of burnout, and symptoms include physical, emotional, and spiritual exhaustion. This makes it more difficult to be fully present for a patient and sensitive to their needs. Strategies to improve this include making time with loved ones, prioritizing tasks, developing and maintaining self-care practices, and seeking support in a confidant. It's important that when we talk about trauma-informed care, you're also taking care of yourself. Since COVID-19, the dynamic between medical providers and patients has changed drastically. Although we've mostly downgraded to just a mask, it is still a barrier to communication in an environment that already generally has a rampant lack of health literacy or ability to communicate effectively across languages. Important trauma-informed care topics for emergency medicine include consent, restraints, sedation, violence, homelessness, and sexual assault. We have here a quote from a patient that reports the experience of being restrained and both the isolation and feeling of helplessness that comes with it. The World Health Organization states that the bulk of the burden of disease and health inequities in the world are the result of the conditions in which people are born, live, work, and age. This means that the health trajectories for all individuals begins in their families, neighborhoods, schools, and jobs. Understanding a patient's holistic being requires understanding their social networks and support systems, as well as helping them access resources to break the cycle of abuse and neglect. Beginning the conversation about social needs can be difficult, but the emergency department can be an important place to address and intervene in these areas, because it may often be their only interface with the health system. We can begin this identification of possible social needs problem with a screening tool. Here we have one through the American Academy of Family Physicians that addresses an individual's basic needs of housing, food, transportation, utilities, childcare, employment, education, finances, and safety. After reviewing answer choices from the screening tool, it's important to then interview the patient in a way that allows them to be active in the shared decision-making process and emphasizes their autonomy and respect. This requires first addressing if they're open to any assistance in the first place by starting with the intro that many other patients receive assistance with XYZ problem to make the statement feel more like a we rather than a you statement. Additionally, avoiding placing blame and judgment on the individual for any shortfall they experience in their social needs, and instead ask what they believe may be in the way of their ability to achieve what they need. And finally, empathy. It's an important tool to gain trust, and this can be an important health need to identify and mental or emotional support in this stressful time. We have highlighted here 4 categories of resources for patients and providers you can make a note of to keep in your pocket for later for understanding how to give a patient resources they may not know exist. It's our prerogative as clinicians to be involved in the community and create relationships that foster support. In addition to these, be familiar with your facility protocols. Like in Philadelphia, the Code Blue helps to keep people experiencing homelessness safe and stay inside the waiting areas of emergency departments. Violence-related injuries are a common experience in the trauma bay or emergency department and can be difficult to interview in the stress of the moment. Remaining calm, remembering to highlight their safety and yours in the emergency department is important to create a space for discussion. Next, although using colloquial or street terms for drug use can be important for H&Bs, it's important to avoid the negative assumptions or implicit bias that may come out as phrases of blame, especially with terms like gangbanger, or just generally placing blame in the bad guy. Instead, emphasize empathy and reiterate it's not easy, sorry to be meeting you in such a situation, but it's important to know what's happened to inform what medical interventions they may need. Then, once the plan is made, relaying that to the patient to know what, and more importantly, why, tests and procedures are going to be done. It's necessary to give them the consent they deserve if the emergent event allows it. More than half of violent crime in the US goes unreported, which makes understanding trends difficult. This Cardiff Violence Prevention Model provides communities a clearer picture on where violence is occurring by sharing anonymized data between healthcare and law enforcement to develop collaborative violence prevention strategies through hotspot mapping data. This is done through these key 3 pieces of information: when, where, and how. Some institutions have a violence intervention program. That is a collaborative between community partners and hospital staff to provide trauma-informed care to individuals who have suffered from violent injuries. The aim is to connect patients with community services to address those basic needs that may be in a state of limbo after such an event, including employment, housing, legal, and mental support. The impacts from this care coordination is seen in long-term evaluations that show HVIP patients being 6 times less likely to be hospitalized from a future violent injury. We all have ownership of this issue, and it's not the sole responsibility of the primary care doctor to address, but we all share the responsibility for trauma-informed care. That includes being knowledgeable about your local programs. The Cardiff Violence Prevention Model has been piloted in Philadelphia, where we are facing a public health emergency against gun violence. Here we have a heat map as of April 23, 2023, showing that this year alone, we've had 427 non-fatal gun injuries and 106 deaths from gun violence year to date. These victims are entering our emergency departments every day, and ultimately, it's not just hurting people, but hurting communities. In Philadelphia, there are multiple violence intervention programs through different hospital networks, but Jefferson is joining with Drexel through Healing Hurt People. This is an interdisciplinary team of an emergency medicine physician, an internist, psychiatrist, and psychologist, as well as a social worker, to address all aspects of health, rather than just addressing the needs while in the hospital. This program is a hospital-based violence intervention program that is an example of peer advocacy that can help survivors in many different ways, including addressing the loss spirals, which is the ongoing sequelae that ensue after a traumatic event, and increase the risk of future exposure to violence due to loss of tangible and psychosocial resources. This organization has 4 main components: assertive outreach, including legal, educational, housing, medical, and mental health support; peer support, which connects community health workers through shared experiences; evidence-based treatment, including trauma-focused cognitive behavioral therapy, motivational interviewing, and mindfulness, as well as trauma-informed care management.
Healing Hurt People is a unique trauma-informed, hospital-based violence intervention program that focuses on young people who have been victims of violence and who are seen in a hospital setting. The program is designed to engage a young person at the time of their injury, when we know when they're at greatest risk for re-injury, retaliation, but especially the symptoms of trauma, post-traumatic stress disorder.
Our patients are really traumatized. We see the symptoms do decrease when they interact with our community intervention specialists and partake in some of the program activities.
The program is designed to treat the mental health consequences of violence and to help young people plug into supports, medical, behavioral health, but also economic, housing, whatever the needs are.
So just before I saved it to the T drive, wanted to see if there was any feedback.
Since its inception and since the replication of the program across a number of other trauma centers in Philadelphia. More than 1,800 young people have been served by the program.
I was a participant of Healing Hurt People in 2011 after I was injured in the midst of community violence. I went to Self Group and I started sharing what I've been learning. I've been sharing the hope that I have received. I went back to college to be a social worker, and I was inspired by the individuals who helped me.
The impact of Healing Hurt People has changed the conversation about violence among young people in health settings.
When we see the improvement of the lives of the young people that we work with, that's our reward.
Or sexual assault response teams at your facility, it's important to be prepared to ensure patients receive the appropriate care and treatment at any time. Cultural competency plays a role in the communication between team and patient. There is no prejudice against victims of violence. This patient population can include all walks of life, and cultural sensitivity is necessary to recognize and respond to that. First step when there is a survivor to interview is that it's done so in a private and quiet area, and that you first assure their safety, as well as empathetic support that emphasizes the courage it takes, and you and your team support if they're comfortable. Comfort and consent of the patient is critical for each step of the process, emphasizing autonomy and understanding it's their choice to stop at any point is necessary, because the process is very intrusive and very overwhelming. Phrasing is also key in building a trusted relationship, emphasizing fact-based questions without blame and avoiding legalese of alleged, possible, and more importantly, victim. Again, the physical exam requires explanation of steps involved to allow the patient to provide true informed consent before any contact and know their ability to stop at any time. A head-to-toe examination is required, but beginning in non-threatening areas like eyes, ears, and nose make the process easier to get into. While referencing the patient to move throughout the exam room, it's important not to call the exam table a bed. That's triggering. Throughout the process, be mindful of other nonverbal cues and make sure that you pay attention to the patient and any signs of distress or discomfort, and allow them breaks that they may need by checking in. Additionally, using a chaperone during the physical exam can provide a patient the comfort and feeling of safety, so it may not be just for trauma experiences like sexual assault, but any sensitive exam, including breast and pelvic exams. It's important that it's offered to everyone, regardless of the gender of the clinician performing the exam. This technique is used with reporting procedures in place to hold providers accountable for insensitive or inappropriate exams that take advantage of patients. Knowing available referral options, like the 24/7 organization and support hotlines, are helpful to informing a safety plan, finding resources, local organizations, and other searchable options. If you want to know more about the trauma-informed care response for topics like sexual assault and intimate partner violence, check out the module for a women's health specialty. An emergency department is often a first stop for many individuals, and as providers, it's important to not generalize and judge patients, but to assess and rule out all different diagnoses that may be the etiology. To do so, we need the knowledge, tools, and skills to conduct a proper H&P. Maintaining safety at all times is necessary and often requires providers to de-escalate situations in triage. A first step in that process are nonverbal cues. Remaining calm and confident is a projection of the space of neutrality patients need in that moment. Staying at the same eye level, avoiding physical touch, and segregating them to a quiet, dark area to reduce stimulation and other distractions is helpful to then begin to better listen to the patient. Allow them to speak while actively listening before restating to show understanding. These de-escalation techniques avoid unnecessary chemical and physical restraints that all assault a patient's autonomy. In starting the history of the patient, begin with non-triggering and neutral questions like basic information and medical history to begin and build rapport without reflex phrases like, I understand, because you probably don't. Instead, reflect and restate the objective situation, like showing you understand their anger and what they're upset about, while highlighting your support and their resilience, while being honest in the support you can actually give them. Importantly, asking directly in a patient indicated to be suicidal in what ways they have thought about hurting themselves may be challenging, but is a necessary question to address after rapport has been established. Normalizing their experience and focusing on a specific issue and how it relates to their overall health is important to address their future care in a multidisciplinary approach. Use phrases like, I have observed that others, blah, 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 instills a necessary hope a patient may need in that moment. Again, a common theme in this module is the discussion of the importance of the provider onus on knowing the resources and tools available to them and their patients to better serve them. Here are some listed to get you started, and remember, the National Suicide Prevention Lifeline changed in 2022 to 988. Easier to remember, but not everyone may know that changed. If you're interested on knowing more about this topic, please visit our Behavioral Mental Health module. Again, we want to reiterate that you can help mitigate the health consequences of ACEs and break the cycle of adversity, and want to thank you for your time.